the lecture 7 by Niharika Madam. So I think uh, today's topic is clinical, preclinical aspects, therapies, traditional and novel. So I am requesting all the participants, please enter in time. Shantanu, are you hearing me? Shantanu?
I don't think we could hear Shantanu. Shantanu, do you want to speak one more time? I don't think we heard you. No.
One thing to the all the participants, tomorrow is the last day, and we will conduct with Madam a that is quiz or multiple type question. No issue. All the questions will be very preliminary from all the lectures we have completed as a host and expert, distinguished uh, expert. So I think uh, the last day we will conduct this one review question overall all the materials and one multiple choice, not a question. I think quiz type multiple think. So, madam, can you that is if you um, enlighten us about this issue, then I think they will prepare themselves.
Yes, sure, Dr. Omik. It's going to be essential, just basics of what you have picked up in these couple of days. So just the basics overall. It's not a exam, it's a basic quiz. And what so it'll be based on, from every day that we did, it'll be just maybe one or two simple questions from each topic. So let's see, we have about a total of whatever sessions we had, just one question from there. And I think you should just look up the basics. Like whatever we did, let's say today for therapies, if you can even recognize the therapy and just say, yes, this is a targeted therapy or this is a chemotherapy, or just to recognize the overall topic and just say yes, whether it's beneficial or it's not, minimally advantageous, simple things like that. So it's just an overall for you to gain some, gain some confidence to say, yes, you did, so the only one that I will say that you don't have to worry so much about is the molecular biology. Don't have to worry so much about that. But the only thing I will say, simple things. If the molecule we keep on referring it like tumor suppressor and oncogene every time, then maybe one or two, just take a little look at it. If it's just the name of the tumor suppressor. So that way, the whole idea is that you can expand your horizon and recognize those words when you go out and read other papers. Um, so you are computer science and IT students, but if you can recognize the terminologies from cancer biology, that would be wonderful. So, so it is a very basic, just like Dr. Bhomik said, a very preliminary kind of a quiz. Nothing
And
deep. So you'll be
and thank you, madam, and for your role. That is what kind of this quiz or multiple type question. And I think today is also interesting topics all are. The second lecture is preclinical studies on animal models and anti-cancer agent. It is also interesting. And then tutorial 8 is histopathological imaging. Then another tutorial, I think, in CNN.
no
And
tomorrow. That's only. So today is
now for our side, madam,
oh,
that is
from
two.
your side, yeah, of course. You
Yes,
have the
tutorial 9 and yes, tutorial 9 and 10. And for tomorrow, lecture 9 is challenges and opportunities of uh, cancer cell, this uh, heterogeneity, resistance to therapy. So I think uh, now we can start. That is 16 participant already joined, and so it is the total thing. Or one in the last session of the tomorrow uh, discussion also in tutorial 11 by madam, uh, that is discussion of writing various research reports. This also important for the all the students.
yes,
Research
absolutely.
article
Very much
is
agree.
how to improve your English and this all this thing. So I think everything will be in the right track, and we are all are in enough confident uh, because all of the lectures may useful in our life. Those are interested in working in machine learning and cell biology, I think. So we are confident, madam, because maybe we are the less participants or the less number, but those are that is solely that is concentrating on your lectures. I think they will be benefited in their future life. There is a no second thought, I think. So I'm requesting you. So that is 18 participants are already with us.
Sure.
So you can start.
Okay, okay.
You
And I
can
totally
start.
agree. I totally agree. And all of you, you have my email address and you can stay connected for future as well. Absolutely.
Because I think whenever the practitioner or the that is the any medical field, any cancer biologist or the radiologist, pathologist, whenever without their help, we the computer engineers can't make any decision making system. So before going for the overall, that is the background of the biological issues, we can't write any program also. We can't that is design a automation also for the any kind of medical imaging. So I think it will be helpful, and I think government of India also, Ministry of Education, I am acknowledged to them and thankful to them, and they have sanctioned this kind of thing, that is the combination of the biological science and the computer science also. So interdisciplinary, that is workshop. So they are nowadays they are promoting this kind of workshops. Only the computer scientists only work their work. No. So in every look and corner, every discipline, we can combine ourselves. And the medical is one of the or the biological field is one of the most I think, important and societal also. The benefit is totally, I think, serve the society whenever we are benefited from uh, the biologist and the cancer biologist. So thank
Absolutely,
you,
I
madam.
agree. I agree, Dr. Homik. My computer science, they are my some of the students are my grad assistants, and I have to explain sometimes the biology so that they can work with us together. So, and vice versa. I think also cell biologists also need to have some computer science background, because otherwise we cannot think like each other. So without any ado, I will now begin the session. We have 22 students. Good enough. Good morning, everyone. Nice to see you again. So, Dr. Bhumi, can I start?
Yes, yes. Pooja, you can formally.
Good morning, everyone. Good morning, Professor Mahatma Madam. Today we are at fourth day of Jan 2025 and title is Biological Cell Imaging for Diagnosis and Early Prediction of Cancer. So today's lecture on clinical preclinical aspects. So ma'am, we can start now. We can start now. Thank you, ma'am.
Thank you, Pooja. So Pooja has given me the official signal. Thank you. Okay, so let me share.
And one thing, I think all the participant when you are active totally, that is, you are concentrating, not a 1 hour, maybe 10 minutes. You are all the concentrating. You may open your webcams sometimes, so it be better because we have to send all the videos to the GAN, IIT Hyderabad, their head office. So I think whenever you, um, that is
Yeah,
for
I
the 10
agree.
and 15 minutes, you can open your that is webcam. Thank you.
Absolutely, I agree. It's, so once in a while, please, everyone, um, just try to turn it on. And doesn't have to be everybody together. Once in a while, keep it on for a couple of minutes. Somebody else turn it on for a couple of minutes. That'd be good. Okay, so we'll
Recording
start
in
this session now.
progress.
I'm also recording on my computer. So good morning, everybody. Our talk today is clinical and preclinical aspects. And there's a lot of stuff in the brackets, but overall, it's really about the therapies, traditional and novel. So, so traditional and novel. Now, in 1 hour, that's a lot to cover, and I will give some overview, and then I will selected some novel therapies that I think you will like, that you will understand, and you will appreciate. And so so typically you all know of these therapies, that the therapies that are called as chemotherapy. Those are all our traditional therapies. They are always there. They're not going to go away. That's for sure. So some these therapies, those are all your very conventional therapies. And along with those conventional therapies, there is always this. So I'm moving on from along with those conventional therapies are targeted therapies. And what is a targeted therapy in cancer? That it's the therapy that acts on a very special molecular target. The molecular targets, like remember yesterday, we talked about growth factors, we talked about tumor suppressor, we talked about oncogenes, we talked about some receptors, maybe once in a while. And so we know that those are mutated, or um, those are not working, overworking. So those are the molecular targets. And so if they have been identified, then that is a very specialized way of attacking. That's a very specialized way of attacking the cancer. So targeted therapies, the word targeted therapies acts on that special molecule. Special, when I say molecule, remember, I always mean that particular protein, that particular set of anything to do with a genetic defect. So we just use the word molecule for all of that. And so if we've already known that, then that's the target. And so that is in comparison to the standard chemotherapies. The standard chemotherapies that act on all the cells, on all dividing cells. They do not discriminate between cancer and non-cancer. So we choose them deliberately, these targeted therapies, okay? We design them deliberately, we choose them deliberately, and they interact with the receptor, the gene, the protein, whichever. And uh, and then we have an idea that they will be very, very specific. So that's how they are deliberately designed. They have to be designed accordingly. And that's the modern way of doing medicine, to design it. And standard chemotherapies are those that are supposed to be able to destroy the cancer cells and along with other cells. And so very much in the past, over many, many years, we have discovered them through trial and error. And that has also been useful in its time. And now for modern therapies, we want to be able to be more focused, and we don't want to destroy all the cells, the normal cells and the cancer cells. So targeted therapies also have an advantage that they have very few side effects. They expect it to. They're designed, okay, at least they're designed to have less toxic effects. That's just how they're designed. Um, and they're supposed to really just not do anything on the normal cells. Now, side effects are always there, but they're designed accordingly. Standard chemotherapy, we know that it's going to kill some of the cells. For example, in standard chemotherapy, the tumor cells are destroyed and the white blood cells. Okay, all your immune cells are also destroyed, and so becomes necessary. It becomes necessary to know that, to know, but then also to treat accordingly, and to make sure that the patient is aware, and that the patient's surroundings, because of immunity lowering, that they have to be more careful. And then so those therapies have to be designed that way. But here we expect much less, way less problems. So just to give you that nice difference between the two, in a standard therapy, although we won't talk about it, all there is side effects, and that's collateral damage. Side effects are all collateral damage, because they will just happen, and we know, okay? So we know that there will be, the immune system will be damaged, the digestive system will be damaged. And so that's kind of like expected. Large amount of side effects are kind of expected. And so here we're only going to target specific molecules. And so therefore, hopefully that other effects are not there. So targets are chosen extremely carefully. That is a major thing. And so after standard chemotherapy was done, it took a while, and we got into much better understanding after the 70s and 80s, and then we were able to decide which chemotherapies to keep, which ones not to keep. And in chemotherapy also, um, we take some advantage of the fact that cancer cells, some of them are rapidly dividing, while normal cells are not so rapidly dividing in some cancers, not all cancers. And so that is kind of the logic for this. But in targeted therapies, it is really understanding the pathway. So only the cell biologists like myself and others who have done research and who have done years and years of research, they will identify that one protein. So whatever I taught you in molecular biology of cancer yesterday, those are the pathways that are then examined, and then the drug is then designed according to that. So there should be no, okay, there should be no collateral damage, but sometimes, there is. But overall, they have benefited the patient much more and the quality of the life of the patient. We call this the QOL, the quality of life of the patient. The QOL is much, much improved. So the idea is that a person who is going through cancer treatment should not die because of the cancer treatment, should not die because the immunity was so low that the person got an infection, which happens a lot. So that is a major thing. Um, so so drug resistance in targeted therapies. All right, it's always a problem. Drug resistance means the cancer was, first of all, was the tumor was getting smaller, and then for after some time, the tumor doesn't get small anymore. The tumor kind of like doesn't respond, and the tumor simply feels that, or the tumor designs itself such that it can bypass, and so that is called as resistance. And we don't use the word drug resistance all the time, but it's just called as resistance. And so that resistance is always there. Uh, there is that you cannot really shy away from it. But then when someone knows the pathway, then therefore there are drugs are designed in such way that they are alternate molecules that can be examined. So Gleevec is one example of a targeted drug, and it caused also mutations in a special protein called as BCR-ABL. Now, I did not cover BCR-ABL, yes, the other day, because we had enough and it was fairly much more detailed. But this is a BCR-ABL mutations do cause cancer, but it is linked to just directly to these mutations. So one can imagine that the effect has to be very, very direct. And similarly, there are other inhibitors, and so I would other drugs. And so if it ends with the word IB, dasatinib, then it is a inhibitor. So that's why NIB inhibitor or INIB is inhibitor. And so this one will target certain members of that same family, so that same pathway. It will target other parts of that same cellular pathway, and so therefore that allows much better choices. While Gleevec, if there's something goes wrong, then there is nothing that Gleevec will work on. It just won't work anymore. So over time we developed new drugs which can target slightly multiple proteins of the same pathway. So, so when patients developed resistance to Gleevec, okay, they were given dasatinib, then again they showed a response. And so that's how treatments are done. You keep changing the drugs a little bit, and knowing the biology is the only way for a doctor or medicine or a caregiver to understand that things need to be changed. And so the NIB again, all right, Tasigna, these are all designed accordingly so that when there's some resistance developing to one, then again another one can be given. And again, remember this: it's the tumor cell that develops some kind of enzyme or some kind of way to pump out the drug and throw it out. The tumor develops all kinds of mechanisms to not work with the drug and to be resistant. All right, which may not be going into in great detail. So So, what makes a good target? Again, it has to be a molecule, okay, of the pathway. It has to be one molecule of the pathway. That is, ideally, it should be only present in the cancer cell and it should be absent in normal cells. So, if the cancer cells have that certain activated protein, then it should work on that. It should not be there. That activated protein should not be there in the normal cells. And so that makes it very, very targeted and specific. But this is just that's like ideal thinking. And so the thing is that it's just not possible always to have that ideal thing, because these, after all, these cancer cells, they do evolve from the normal cells. And so it's often not possible that you would have that it would work on the cell that has the activated gene, but normally the gene is also working in normal cells, so it can affect both. So you cannot use that kind of a target. And so if that's not ideal, then the next best, that's why the language is like this. The next best target is a molecule, that protein or that molecule or that enzyme, which is more frequently present in the cancer cell. If it's more frequently present in the cancer cell compared to the normal cell, then there's a good chance that before the normal cells are affected, the cancer cells will be affected first. So, and this can be done, therefore, by adjusting the dose of the drug so that the cancer cells are killed in with a lesser dose, or with the dose that will kill it, but not kill the normal cells. So typically, this is the mechanism. We do have to take that risk where they're just where it's not the ideal situation, but it can be adjusted by a dose. And so, not to scare you, but this is all the approved targeted therapies. So rest assured, I won't be asking you hordes of things from here. But just to show you that Gleevec was first approved in 2001, and it targeted the BCR-ABL. It targeted BCR-ABL on these some of the blood tumors, blood cancers. I'm sorry. So you was there in CML and ALL, and it was a very it's worked pretty well. So whenever you see a name that ends with NIB, so those are all nice way to know that it is an inhibitor. That means it goes and it targets something and then just inhibits it and kind of shuts it down. So it targets the receptor. So here it is, EGF receptor, and if these receptors mutated. So I would not go to all of these, but maybe once in a while we'll just come back to some of them. And so we've had good luck with breast cancer. We've had good luck with the other blood cancers. And with pediatric ALL, we have our newer ones here are CAR T cells, are directed to the CAR T, and so we will look at that today. So, and some of them, they were developed, but then they did not stand for too long. It just didn't. For example, no, I don't have any example right here. Some of them just did not. So this is all current because those are the ones that are still going on. So I took only the current ones that are still being kind of like being used. So small molecules. So small molecules are the targets for therapy. So small molecules means these are proteins that are that are in the tumor, the proteins that either the tumor is making or the tumors are the proteins that are present on its surface or it's secreting it. So if the tumor itself is secreting this is the protein here, and you see that in this tumor, so this is a tumor cell here, and that's the same protein that we're talking about. So if it's if it's a small molecule and it is being secreted by the tumor by some way or by some kind of a cell. And so this is just to show you that this is the cell, this is the cell surface, and these are all receptors. So that is a receptor. This is a receptor on the top of the cell that will probably receive that this small molecule. And once it receives that small molecules, a big signaling activity starts inside the cell. So major cell signaling goes inside the cell. So small molecules. So let's just look at small molecules. And I'm starting off with a not a very good successful trial, so or a successful one. So this is called as the metalloprotease. Remember we talked about the MMPs, matrix metalloproteases, which are like they're just enzymes that just chew. So this they'll just chew they will chew the ECM. So if this is the tumor and these are the outside the ECM extracellular matrix that is outside the tumor. And so if there are extracellular matrix proteins, then the MMPs, if you remember, they're supposed to chew things. Here it is. It just chews things such that the tumor is able to, some cells are able to escape. That was the biology, if you remember. So MMPs are enzymes that are supposed to degrade the ECM. And so some of those inhibitors were designed, but they were not successful. And the reason why they were not successful, because this works in the ECM, and now the ECM early on, remember the tumor microenvironment very early on is working with everybody in the microenvironment and dictating what to do. So early on, the ECM has a major role, and so if this was used in the early stages, it benefits. But if it's used in the later stages when the tumor has really, influenced all the tumor microenvironment proteins and the cells, then it just doesn't work. So it was kind of like when it was given, all right, it was given, the diagnosis was already done, it was already late, and the drug just would not work, and it only worked in early stages. And the problem is a lot of the cancer, they're just caught very late. You just can't. So just this was kind of like not used after all. It was taken away. So the next one are monoclonal antibodies. Monoclonal antibodies. So this is a cell membrane again. So this is a cell membrane just to show you. And here is a protein. This is a protein that belongs to the cell membrane. So this is the whole cell, and that's the surface of the cell. And this protein, it's going on the inside as well, just not being shown. And these are these monoclonal antibodies that will go and kind of like recognize them. So monoclonal antibodies, um, they were designed, okay, they were designed to go and bind to those substances again that get released. And so to bind to signals or substances that, for example, cause the vascularization of the tumor. So do you remember that is able to produce, the tumor is able to produce um, a signal called as vascular endothelial growth factor, VEGF. And so VEGF, it keeps on producing VEGF. So here it is, it's producing VEGF, and then VEGF goes out, and VEGF and goes out, and it affects the blood vessel. So this is VEGF that it just released, and it will go out and affect this blood vessel, and it will start to branch in some more. So it starts to branch in, and it covers and makes more capillaries. So VEGF that either the tumor secretes or another cell nearby, if it secretes it, wherever it is, wherever the signals are from, this this antibody. An antibody is a very, very specific protein that looks like a Y. It looks like this, okay, in schematics. So let me just go back here. It always looks like a Y like this. That's the way we draw. Um, so it's like somebody with two arms out, and it will just go and catch, it will just go catch it in the two arms. So it'll catch it here. You just see how it just catches here and it just catches it here. So an antibody is a protein with a Y shape, and it will go and it can catch, it can bind, the best languages is that it can bind to the VGF. And so here it is. This is your Avastin. It doesn't look like a Y shape here because of the bulk of the molecule, but in schematics, that's how we show it. And so here it is. Go to the left top on red against red. Sorry about that. On the red top, you see the Y-shaped molecule, and that is going and binding to um, this here. That is your VGF. So the antibody binds VGF. And antibody binding is a signal, means that the signal is just not available anymore. It's there, but it's not able to go to the blood vessels and affect the blood vessels. So it keeps it away from the receptors of the vascular blood vessels, the vascular cells, which is called as the endothelial cells. And what are the endothelial cells? The endothelial cells are on the inside. If you look on the right hand side, I'm drawing it. They are on the inside. They are lining the blood vessels. And I showed you a video how they form a tube-like structure. And so now you see that this is Avastin, and uh, it is bound to the VEGF, and so the blood vessels are less. So less blood vessels are being made. And so if the tumor does not get its enough supply of glucose and nutrients through the blood, then the tumor will be able to maybe shrink over time, or it will not grow at least. So preventing new blood vessels from to be formed. So vast means from vascular vessels, and avastin. And so whenever you see this is the trademark, and whenever you see a name that ends with MAB, bevacizumab, MAB means monoclonal antibody. And a monoclonal antibody is kind of very specific. It will not go bind to any other signal or molecule. So it will not. So monoclonal antibodies are made. We make them. mm, It's a big process to make them, but they recognize very specifically certain molecules. In this case, it's VGF. And so that's again, that's the cell biology basis, or the molecular biology basis for you to understand. Okay, and I will have something for you, for besides the cell biology stuff, some more different examples for you. So let's look at another mob. Okay. Oops, sorry about that. Let's look at, okay, retux rituximab. Okay, rituximab is, mab means monoclonal antibody. It means it's going to be expensive also. Anyway, but it is a monoclonal antibody that activates the immune system to attack the cancer cell. So what it does is that the B cells, okay, so our lymphocytes, we have lymphocytes, our lymphocytes are of two types. The lymphocytes in the blood, they are T cells and they are B cells. And B cells, they make antibody, okay? They make the antibody. So B cells, they're called as B cells. And T cells, what they do is T cells will go and kill. They go and they play tag. They go and touch that the cancer cell, and then the cancer cell can get killed. So they can kill. Okay, they can kill the cancer cell, but they have to touch it. They have to go and bind to it. But anyway, the B cells, they make these antibodies. So these B cells, here's some knowledge for you, is that these B cells, they are on the surface of a on the surface of the membrane, and and the name of that surface protein is called as CD20. And just for you to know that you will come across CDs. All right, so CDs are nothing but, so look at the bottom, please. CDs are nothing but a specific marker, so it's like an identifier. So these are various proteins and sugars that are they stick out from the membrane, and we use these CDs as identity markers. Okay, so we use these CDs as identity markers, and so it's called as the cluster of differentiation, and that's how we just name these proteins, or you know, that are on the surface. So CD20 is that name, and it's located on the mature B lymphocytes. Okay, so and so here's your normal cell. Here's your normal B cell, and this is in the blood. It's all circulating in the blood. You can see that it has a nucleus, and that's the cell border. And this is your B cell that is kind of like malignant. That is also already cancerous. So what it will do is it will go, and an antibody has this characteristics where it can, so look on the right hand side, it can bind to this CD 20, and then what it will do is it'll activate. Okay, so it'll activate these some of these good cells of the body, and so it'll activate them, and then they can go and attack these cancer cells. So it is dependent on these these good these cells to go and attack the other cells. So we use antibodies for activating them to make them work some more and not just stay not doing anything. And this is kind of useful because the it kind of like increases the sensitivity of those cancer cells, all right, who are not doing too well on chemotherapy, and it can help promote cell death. It can promote just removal of those cancer cells. So the next one is Bexar, which is not made anymore by the company, and so the Bexar is Tositumumab. So big long name, and it is a radioactive. It is a radioactive immunotoxin. Okay, it's a radioactive immunotoxin, and that's a fancy immuno that's a fancy mechanism. So this radioactive this Bexar, it can treat blood cancers. Okay, it can treat blood cancers like non-Hodgkin's lymphoma. That is, the lymphocytes are cancerous, and if the patient has CD20 positive cells, so that means the cancer has to be on those lymphocytes, and they have to express it. So they have to go and express it. Okay, so if they don't express it, then it cannot be useful. So those cancer cells, they have to express the CD20, and so then it binds to it, but the it radioactive iodine is present along with it. So if radioactive iodine is present along with it, so here it is. This is the cancer cell now, and it has the CD20. So that's your CD20 here, and that's your antibody that is radioactive. So radioactive because it has radioactive iodine attached to it, and it's very, very specific. It will just release high doses of radiation that will kill the cell. And over time, this was not a preferred method, so it was gotten discontinued. But I thought that that's a very nice, smart way to specifically target the cells. So let's look at something that's really, really novel. Let's look at something that's fairly nicely novel, and that is CAR T cell. So So CAR T cell therapies. So chimeric antigen receptor. Okay. So, so before I put in some technical words there, I just thought maybe I'd explain it first in very simple words, okay? In very simple words, what the therapy is. So it's like the whole story, and then I can put in some technical words. So a CAR T cells are chimeric antigen. A chimeric antigen means chimeric is another word to understand it. Chimera means like a hybrid. Chimera means a mix of two things. So chimera kind of like means like a hybrid, but I would not use the word hybrid. Chimera is, like 80% to 80% one protein, 20% another protein, or a hybrid chimera can be 70% of one protein and 30% of another protein. So that's your various chimeras. And so we make these various chimeras. And so what is done here, these various chimeras, for your own T cells, for the patient's own T cells. That's the important thing. So the patient's own T cells, are taught to go and target the cancer cell. So your own T cells, which go and which should be able to recognize the cancer cell. So what a cancer cell, tumor cell does is it tells the T cells, "Hey, I'm your friend. You don't worry about me." And so the T cell just sits there. I showed you a video yesterday. The T cell just doesn't do anything to the cancer cell. It doesn't kill it um, because the cancer cell manipulated it. So what we can do is we can take the patient's own T cells. So here it is. You take the patient's own T cells, um, and you don't need to take everything. You just need to take some, and then you collect them. And then you collect them and you put them in tissue culture, and so that's the beauty. And then you can train them. You can rewire them. So rewired, they are rewired means they are taught by some genetic manipulation. All right, that they can be. We can put in a brand new receptor that they can then recognize. So here it is. These are your regular T cells from that patient, and so what is given through through some kind of manipulations using some viral genes, etc. They are processed, and now look, they are recognizing these special. They are able to recognize these special cancer cells. So they're made such that they will recognize the cancer cells, and then they will be made to grow in the cell in the tissue culture lot. So you have a big population of all of these. So you make lots of it. Make a lot of it so that it just circulates in the patient. So when you make a lot of it, then it's ready. Now what happens is that, in very very simple language, these so they recognize. So we'll talk about it in a second. So they recognize this. They they are going to be they are made to recognize the CD19. So this marker CD19, they are made to recognize this, and you see that they are expressing all of these, the CAR gene. So the CAR gene is the chimeric antigen receptor. So they have all of these receptors are made. So each of these has receptors. So these are, I wiped it off, but these are all your receptors. And so all of these receptors will now, for CD19, they will now go be put into the patient. But they can only be put into the patient when, first of all, so look up here, when the patient is all the lymphocytes, are kind of like um, killed. All the lymphocytes are kind of have to destroyed first by some chemotherapy. So some chemotherapy is done. So with chemotherapy, the original lymphocytes are kind of like destroyed. And when the original lymphocytes are destroyed, then the patient is ready. The patient is ready to take these new CAR T cells. All right, and the CAR T cells have these receptors that will go and recognize the tumor cells that are in the blood, okay, that are in the blood. So therefore, if there is a B cell leukemia, if there is a lymphoma, if there's multiple myeloma, okay, these T cells have your own T cells. The patient's own T cells have been manipulated. So these T cells have been harvested. Harvested means collected, and they are genetically engineered with some with and with some viral genes, etc., that recognize this CD19. So, and CD19, who expresses CD19? The tumor. The tumor expresses CD19. And so if the your own T cells are making receptors, then well, all that happens is that um, the it is almost like a antigen antibody like recognition, technically speaking, and so it can lead to the death of those cancer cells. And so it will like it will go like find them, it will like find it out. So I have this diagram for you. Sometimes it's good to just understand things with a diagram. And so here is your that's your new CAR T cell. And so it has the CAR genes that are inside. So you have to really put in DNA, etc., and for it to make this receptor-like molecule that will, uh, that will recognize the CD19. So what do we have? You have, this is your new CAR T cell. This is just showed in bigger, and one of these is shown here. So it has the CAR protein that is recognizing, that is able to recognize CD19. And where is CD19? So this is your cancer cell, and CD19 is a protein that is a recognition marker that is here. So for this, the patient's own lymphocytes have to be destroyed, and then only these are delivered inside. So so that is, and so this is all regarding whatever is done with the DNA. And so that same picture one more time. Okay, so blood collection. So just wanted to show you how it's done these days. Nice blood collection. Not everything. You cannot take all the blood from a human being. So they collect some amount of blood cells and that go into tissue culture, and then they are kind of like um, all the good T cells are taken and the blood is all removed, it's returned. So the blood goes back to the um, patient. So it's really like, filtering and separating out only the T cells. Okay, so obviously, just take a look. Oops, sorry. So obviously it will work in B cells. So if you're taking T cells, then the cancers that are B cells, the cancers that are B cells, those are the ones where it will work pretty well because you're taking out the T cells. So obviously you're not going to do it against a cancerous T cell. So blood is returned. So and it's the blood is returned. The T cells are now removed, and they go to the lab, and by all genetic engineering, now they are those beautiful looking CAR T cells. So CAR T cells are then they have to be grown. So then you go put them in tissue culture flask. I gave this diagram because I showed you a tissue culture flask like that. And so you just grow a lot of CAR T cells, enough to get a good response. And then during this meantime, this is not happening all in a day. It takes some good amount of time to do this. And so in some in some days, the patient is given chemotherapy. And then the patient takes the CAR T cells and is introduced into the bloodstream. So there it is. It's introduced in the bloodstream. So so this is the very simple mechanism. So I hope you have learned something that is marvelously the from genetic engineering to cell biology. and that your understanding is improved. And of course, you're going to obviously use it for B cell lymphomas. So, just give me a second. What are the types of CAR T cells that we have right now? So they have these fancy names. So these different CAR T cells, they will target specific surface proteins. So here, so they will, for in this case, it was CD19, right? So for different situations, they have to target different specific proteins. So CD30. So here it is if you look at the bottom, um, it is CD19, and then there's one for CD30 for Hodgkin's lymphoma, and there's two other separate ones for multiple myeloma. So that target protein, of course, must be expressed in that cancer cell. And an important thing to note is that the target protein must not be expressed somewhere else in the body. So sometimes it can be, if it's possible that it's expressed by another cell type, then that would be a problem because then it's going to go and target them. So these are some nice examples for you. And so this is how targeted it is. This is a targeted therapy. And this is fairly new. This is as of today. These are the current CAR T cell therapies that are currently out there. And so there are six of them for a specific kind of blood cancers. And I just put these names in here. All right, Kimria, Brianzi, Avisma. So these are some kind of the. Then this one I've heard about, Carvicti. And so these are just to give you a sense that they are used for these kind of treatments currently. And so these are, most of them are B cell lymphomas, most of the B cell lymphomas. And if it is, then it just should be such that it doesn't hurt any other cell. And so solid tumors are not there yet for CAR T cells. It's going on in research still for solid tumors. And because the T cells are circulating, they're circulating in the lymph and in the blood, so it's kind of like possible to do that. Solid tumors, the cells have to be available. The it's just a lot of more. There's a tumor microenvironment, so because of the tumor microenvironment, so that's why it is much more complex, and so that's why they're still in research. So remember that the tumor microenvironment has so many other types of cells also, and so that's where it's a bit more. So who can get these CAR T cells? What is the eligibility? So it can only be that type of cancer that the CAR T cell can target, and has shown that standard therapies, they probably have to kind of like shown that the standard therapy was not more working, so it was still progressing in the standard therapy. So that's why they will get CAR T cell, because it takes time to make it, and so maybe it's a relapse disease, and there's really no other way. And it has to be a measurable disease because we have to know um, how much more to CAR T cells to give in. So this has to be everything is measurable, has to be measurable in some way. But most important that the cancer has to express that targeted surface protein. So whichever we have, that's the only one that they can do. So whatever we've found so far. So targeted surface protein has to be expressed. If it doesn't express that, and it is probably that maybe it's a B cell lymphoma, but it just doesn't express it for some reason, then it just won't work. And so I just wanted to give you an image of the morphology CAR T cells. Not that, not that it matters for you, because this is a intervention, right? But as a academic interest, it's kind of useful to know, how they look like. Uh, so, so these, so anything that has a nucleus, these are all the ones that have a nucleus. These are all, these are all your, T cells to begin with. And so, so there's a, this has a heterogeneous population here, so it's just hard to tell. So this is already pretty heterogeneous. But just to show you that various different kinds of T cells are present. So it's kind of like hard for me to say which one. But here in B, all right, on B on this side, okay, um, it keeps on saying residual CAR T cells, because the CAR T cells are in mixed with the other things. All right, so the CAR T cells here in this one are washed out from the infusion bags of the patient, and you can just see very large hyperbasophilic cells, all right, that are of there with other multifolded nuclei. So these are some of your large ones. These are some of your large ones. Again, this is not needed for any diagnostic purposes, but who knows, it's good to take a kind of look at it. All right, so the only problem with CAR T cells, and I think this is the only issue that people that you might want to, you as a computer science IT student might want to really go and analyze CAR T cells and see if there are data sets of these, of more images, and to be able to identify them. The own Because of this major problem of toxicity. And toxicity of CAR T cells, there are more publications I found of CAR T cell toxicity, of problems of the patient later on, and that has to be cured. And so one real thing is that there's something called as the cytokine release syndrome. It's whenever we, typically whenever we give a blood transfusion, a lot of transfusion to someone, there is a response. Typically if you give someone a lot of blood, there is some kind of weakness, a little feverishness. It is a natural response. So it's something like that. It's cytokine release syndrome is a toxicity. And what happens is that there is low blood pressure, there's fever, and there is difficulty breathing, or, there's difficulty getting enough oxygen. And then it looks like maybe the patient probably just developed an infection, but not really so, because after chemotherapy, white blood cells, they they're less, and people can get infections, but that toxicity is maximum. And so now this is just one example. There are other toxicities that people have also started to find. And so let's move on now to something that is, I chose this only because, as engineering and computer science students, I thought that this would be nice for you. So there's so many, but this one is good because it's has very potential. So targeted radioligand therapy, RLT, radioligand. So obviously there is some kind of radioactivity, etc. stuff like here. So um, so this is a PSMA is a protein that's on the expressed in not on expressed in the prostate cancer cells. So it's a prostate kind of a prostate kind of an antigen. And so it is expressed in prostate cancer cells, and it's a transmembrane protein. So if this is your cell, then it's a transmembrane protein like this, and so that's your PSMA. And so PSMA is increased. There's a lot of it in prostate cancer cells, and so these are the prostate cancer cells that will express it. So there's more of this. So there's more of not only of the cells, the prostate cancer cells are more, but there's more of PSMA. And so that becomes, it's different from the normal prostate cells. And so that's a good difference to see. So what is the therapeutic concept here? They couple a radioactive substance, they couple a radioactive nucleotide to a small molecule ligand. So you have a nucleotide and you have a ligand. What's a ligand? Ligand is just nothing but a signal, or a substance that recognizes, has high affinity for PSAM. So if I can draw it on this side here, so you have this radioactive substance. You know how they draw radioactive substances, like, so this is going to be your reactive radioactive molecule, and it is bound to some kind of a ligand. Okay, so that will just go and recognize just that transmembrane protein. And so when it recognizes, it delivers when it recognizes it, it delivers a radioactivity. And so it delivers radiation only to the tumor cells. See how pinpoint? It's very nice. And currently, this has been used, and so it only gives radiation so close to the tumor that it really does not give any radiation to normal tissues. So that's the beauty of it. And so this enables this so enables PET imaging. Remember, we talked about PET imaging, and I showed you a video of PET imaging. And so it can be seen, and it can be examined as to where it's going. So, and the word is, it enables theranostic, therapy and diagnostic, two words together. So you diagnose, and the therapy. So you diagnose it by giving it, and if it goes and binds to it, therapy starts right away. So theranostic is a newer kind of modality of treatment and screening at the kind of like the and detection at the same time. So one that is very a famous one is, and so I will not read the whole thing of what it contains, but Pluvicto is approved for metastatic, okay, very metastatic. People die, so this is advanced castration resistant prostate cancer, where cutting off the prostate will also you know not work. The prostate cancer is so kind of like metastatic at this point. And so these are already in phase 3 studies, and they target via. So this is a very new paper I found for you. So I have this picture here, and I did not refer to this picture because I can refer to it now and show you how it works. So and so here is so let's look at the top, and let's look at the top here. So you need to understand the biology behind it always, so that you remember it. And so this is your prostate cancer cell, and it has a nucleus, and the whole idea of giving radioactivity is that the radioactivity will not kill the cell from the outside. It will go and damage the DNA such that the cell dies. That's how radioactivity typically works. That's what we plan. And so that's why the nucleus is shown. And this is these are these alpha particles that are released, and it goes and cuts the DNA. Okay. And so let's look on the outside here. There's this big complex molecule, it seems, all right, or protein, and it has a ligand. Okay, so this is just too small. Let's come here and let's look at it. The whole idea is that everything goes inside. It is taken up by the cell. It's recognized. So PSMA is on the surface of the cell, and the whole thing will come and recognize it, and then it will stay bound, and everything will be endocytosis. By endocytosis, it'll all be taken in. So it goes inside the cell. It just does not stay outside like we were talking about before, but it actually actively, because of PSMA receptor, it actively goes inside the cell and it delivers it. And this is a really wonderful way. And so this radioactivity will cause strand breaks. And so now let's look at it a bit closer. So this is at the bottom here, just look at it closer. So this is your RLT. And so this is your molecule that is going to deliver AC225, that is going to deliver the radioactivity. Okay, once it's inside, so it will, the radioactivity will be, I don't know, I think it's kind of like activated once it's kind of like inside. Uh, and so there, so it is bound to a linker molecule, and this linker molecule is able to recognize, it is able to recognize this whole protein. It is able to recognize this whole protein. There you go. That this whole protein is your PSMA. Okay, so this whole thing is your PSMA that is there on the membrane, and so this is the cell membrane. This is the cell membrane, and there's a nucleus here somewhere. All right, and so this is, whole thing is PSMA, and so you don't need not go into the details. And what will happen is that this is actually, this is the well, actually, this whole thing is PSMA. And so the way it's designed is, see this, the way it is designed, that it will fit, and it will bind. And once it binds, then the whole thing caves in and it goes in. So PSMA, okay, this whole thing is PSMA. Okay, and so all that was done is really creating this linker, along with the radioactive component. So, so I thought I'd just show you a histology specimen. Not that it's labeled, and I got this from a paper. I can't see if oh, I did not put in. I did not put in the reference for this paper, but I got it through a very recent paper. Actually, it's the same paper that discussed this therapy, and it just shows you. So all of these here that are these are the nuclei. These are all the nuclei, and you can see that there are other nuclei here that it kind of like is able to target. So these are the kind of like the normal ones, and these are the ones that are breaking in. So and so so you will see some of them that are being targeted here. Now, this is not exactly a histology course right here, but just to show you that they can be examined. And the whole purpose for me to show you this is that if you are able to find images, a whole compilation of such images, then you might want to consider, following, how to follow treatment. Is there any way, when the radioactivity is activated on the inside, when it is activated on the inside, are you able to follow any of the cells? Is there some machine learning capability that will show you that yes, these are the cells that have taken up the radionucleotide, all right, and they are slightly different, um, and um, and how to go about looking for them. Now, it's very much possible that they can be located because it's being radioactive, but you should be able to look for other visual ways to see if there are immediately early changes in the cells or not. And so therefore I just put this in, honestly. So, in conclusion, novel therapies, they have a lot of promise. I did not give you all the others that they're there. Cancer stem cells, I'll just take a couple of minutes. I thought I would not speak of cancer stem cells, but cancer stem cells, they started out pretty well, but they're not used very much. All right, and so that's why I thought I would just talk a little bit about cancer cells, but stem cells, but more about these others. So, cancer stem cells, although not discussed yet, but they lead to tumor recurrence. Okay, so they had promise some years ago, um, and the thing is that cancer stem cells um, are not novel anymore because they also express these markers, and that are expressed by normal cells. And so, cancer stem cells, we will not go into any details of the cancer stem cells. It's because we did start off, the title has a cancer stem cell, so I just thought I would still just deviate and just let you know that the potential of cancer stem cells currently is gone. People are continuing to do research in the hope, but we have CAR T cells have kind of like taken over. So with that, I thank you, and I will take um, any questions. So Pooja, you can now hopefully, um,
Hello, ma'am.
yes, please.
Yeah, I have one question.
Yes, please. There was
Okay.
Smita. Is that right? Did I hear?
Yes, yes, ma'am.
Yes, there was
I
Smita.
wanted to ask whether there is a possibility of cancer recurrence after treatment with monoclonal antibodies, even if the cancer cells have initially been eliminated.
Yeah, that is a that can happen. Monoclonal antibodies, that can always happen. It's not like it can't happen. Why not? That can Those things nobody can predict. The reason being that we start out always thinking that it will never happen, okay, with these
Yes,
monoclonal antibodies, and it's a good thinking. But the bottom line is that all these monoclonal antibodies, they're targeting different things. So some of them are targeting the vascular endothelial growth factor, right? Some
yes, ma'am.
are targeting normal B cells, and so there are a lot in the market, which is a good thing, and that's fabulous that they are there. And so, some of them, with the antibody, it's just hard to say that monoclonal antibodies are always the best. Yes, they are extremely specific. And so I don't have any special example of which one, but it is recurrence is possible for many of them. And so, some of the cancers, if they're like non-Hodgkin's lymphoma, is also
Ye-
already, pretty aggressive. So if it's a non-Hodgkin's lymphoma, and it is treated with the monoclonal antibodies, um, it will work for sure. But this lymphoma itself is already pretty aggressive. So that's a
Both combined, ma'am. Both
yes,
combined.
yes, exactly. So with combined treatment, etc., it would work. But if the for non-Hodgkin's lymphoma is like, I would just say that that's already a pretty hard one. So therefore, the way that it works is that you have to have a combined treatment, then you have to have another phase of kind of like a different combinations, and uh, uh, different combinations and therapies have to keep going on side by side. And so non-Hodgkin's lymphoma still, like I said, remember, about 60 to 70% survival.
Hmm.
So the 30% or would probably not have made it. And you have to give this thing, the tumor cells or the cancer cells, they find other means. So yes, that's a good
Yes,
question.
ma'am. Thank you, ma'am. Thank you.
So, Dr. Bhomik, Pooja, others,
Th-
I'm getting a little tired today.
Thank you so much, ma'am. Uh, is there any question from the participants?
Yes, we'll have some good time to interact also,
Recording
tomorrow
stopped.
for when we discuss the paper. So it'll be nice to have a discussion session tomorrow when we do that tutorial with all of this combined.
Okay, ma'am. Thank you so much, ma'am. We
Thank
can,
you.
after 15 minutes, we will have our lecture 8. So we can go for a 15 minutes break.
Absolutely.
Participants,
Absolutely.
participants be there. Don't leave the meeting. Just mute yourself and
Yes.
okay,
All
ma'am.
right.
And
Thank you.
one thing, next presentation is also most important. I am requesting all the participants, please. And most important, why you can see, or you can uh, that is one presentation from the Niharika madam, histopathological imaging, most important, I think. So we will, uh, all of you, I will see you again at, I think, after 15 minutes. Thank you.